So let me get our first session underway, which is called Reality Bites. This is where we get the cold shower of truth about what's actually going on in our healthcare system. Our guests for this session are Stephen Boyle, who was appointed Auditor General in July 2020, and Stephen's responsible for auditing around 40 billion of taxpayers' money. He audits all public bodies except local authorities, including the Scottish Government, NHS bodies, police and fire, further education colleges, and most non-departmental public bodies. Audit Scotland has produced a series of reports on the health system. Each, for my money, has been more alarming than the last. But we're delighted Stephen has agreed to address us today to kick things off, after which he and I and our second guest, Sarah Davidson, will have a conversation. Sarah, since 2019, has been Chief Executive at Carnegie UK. From 1995 to 2019, Sarah was a very highly regarded civil servant working for the UK and Scottish governments in policy and operational roles. Her last post in the Scottish Government was Director General for Organisational Development and Operations. So with that, I'm going to invite Stephen to get us underway with your speech. Thank you, Stephen.
Chris, thank you very much. Good morning, colleagues. Firstly, how delighted I am to be with you this morning. Thanks very much to colleagues at Enlighten and to the Royal College for inviting me to such a wonderful venue in the heart of Edinburgh. It's a real pleasure, firstly, to be with you. I guess to say a bit more, as Chris has referred to, about much of the work that Audit Scotland has produced, not just in my time as Auditor General, but really for many years now, about the financial position of the NHS, its performance, some of the challenges that it faces, and much of the drivers for change and reform of how the system is currently operating to produce better outcomes, better public spending than we are currently achieving. As Chris has mentioned, I've reported many times on the unprecedented challenge facing the NHS in Scotland, the urgent need for reform to ensure not just future generations as well, thereby safeguarding the NHS that so many of us cherish now and into the future. In terms of the money, it will come as no surprise to anybody that health spending consumes the largest part of the Scottish devolved budget, around 40% of public spending. And we've seen some changes to that number. Every year you will hear that there's record investment going into health. That's not really a surprise, because I think what we see is that that investment tends to grow not just in terms of keeping up with inflation, but also real terms growth as well. 23-24, for example, saw a 2.5% real terms investment increase in the health budget. And yet, although we've seen budgetary increase, rising demand or operational challenges, together with growing costs, there remain those pressures within the NHS. And we're clear in our reports that without reform, there's a real challenge to its long-term sustainability. What we've also found is that there's only one size, there's only one pot or share of the pie, and if health continues to grow, what then for other parts of public service? And those vital parts of public service that deliver for all of Scotland's people, whether it's education and training, welfare services, and the housing provision, each and every one of them matter. But what's also true is that they all play a vital role in contributing to our wider health and well-being. They play a part in supporting health and social care in Scotland today, but certainly into the future as well. Direct health spending, as I allude to, is growing faster than other parts of the devolved Scottish budget. The Scottish Government has made progress in recent years in terms of being more transparent in its medium-term financial spending plans. My organisation has been calling for what's called a medium-term financial strategy for many years, and that's now part and parcel of how the Scottish Government sets out its intentions. What we've seen in the most recent version is that health and social care spending is going to grow by 5.3% to the end of this decade. That contrasts with 2.6% for other parts of the devolved Scottish budget. We think there's a question mark, clearly, in terms of whether that's sustainable into the short term without reform. Long term, short term, medium term. In Audit Scotland terms, we encourage long-term planning. My colleagues, though, at the Scottish Fiscal Commission have taken this to a different level. You go to 2048, Chris, they've raised that to 50 years into the future with their analysis and demand projections. The SFC, therefore, saying by 2075 is going to grow to 55% of the devolved Scottish budget. We talk about cuts or reform. In many ways, you could read one and the same. It's about sustainability. If health and social care into the future is consuming 40, 50, 55, and who knows what else, the question is that achievable, sustainable, and can it deliver the value and outcomes across all parts of public sector? And we think the answer is no. That makes a strong case for reform. We're also seeing some of those challenges laid bare here and now at a local level across some of Scotland's health boards. And that record investment, the record investment that you will hear about is going through the annual budget setting process, isn't making a difference to the financial position of Scotland's health boards. In the 22-23 financial year, 5 of the 14 area or territorial boards needed loans from the Scottish Government to break even. That number has increased to 8 in 23-24. So loans, brokerage, year-end funding is all having to be found so to help Scotland's health boards to break even. While health spending has increased, the NHS in Scotland is treating fewer patients than before the COVID-19 pandemic. Most of the national waiting time standards aren't being met, and nor have those commitments made to reduce waiting lists also. We see pressures day in, day out across the system, highest levels of delayed discharges in places, and long A&E wait times in some of Scotland's emergency departments. Unless the NHS in Scotland increases, therefore, hospital activity in tandem with a greater focus on prevention, and that, of course, I mean policies and investment that improves the overall health of the nation to reduce the demand upon the NHS, it's clear that that risk of waiting times and waiting lists will remain with us. Following COVID-19, and as I referred to, despite the record investment in spending, more people now employed in the NHS, hospital productivity has fallen significantly. The IFS, and I'll quote them, said, without substantial boost to hospital productivity, there's a risk that even greater funding and staffing will not bring the Scottish NHS back to its pre-pandemic performance. Easy for me to talk about productivity. I am not an economist, and it can sometimes feel like quite an abstract concept, and it is complex. And there are different factors that can be driving the reduction in productivity in some of Scotland's hospitals. At a headline level, though, I think it is true that there's been a constrained investment in infrastructure, workforce factors such as vacancies in key services, increased staff absence, patients requiring more care in Scotland's hospitals, that they're arriving sicker than they were before the pandemic, together with the delayed discharges challenge that I alluded to earlier. Challenges in infrastructure, though, are here. We've seen that increase post-pandemic. There is a real tightening and constraint upon the capital investment budget, not just for the NHS in Scotland, but across the piece. Changes in some of the government accounting rules, the availability of different paths of finance, have all required the Scottish Government, and really governments across the UK and devolved nations, to prioritise ever thus. Specifically, though, what that means that the available capital investment budget is neither sufficient to invest in new facilities nor to maintain the buildings that Scotland currently has to deliver health services. Backlog maintenance, which I don't have the precise figure in front of me, runs into the billions for Scotland's hospitals just to maintain what we have. During the pandemic, there were many policy announcements, but one of the most eye-catching at the time to deliver change and recovery was the introduction of a development of national treatment centres in Scotland. One of the key measures at increasing activity and addressing waiting lists. 5 of those national treatment centres are now operational, but there was a pause on the development of the other planned 5 at the end of 2023, and there's not now been an announcement or a revised date set for when these projects will be restarted. I refer to the constraint on the capital programme as being the real driver behind that. So what that leaves us then is a gap between capacity and demand that's likely to grow without further intervention. It's unlikely to be bridged solely through performance improvements unless planned care capacity is increased and there's transformation in services and models of care with a focus on prevention, care closer to home or at home. Colleagues, in my view, all this begins to make the case for why reform of our health and social care models is urgent. Its scale and pace must increase if this pressing capacity and affordability issues are to be addressed. Together with my predecessors, we've regularly made recommendations on the need for NHS to drive forward innovation, undertake long-term fundamental change to secure improvements in services and better value for public spending. A sustained focus on preventing ill health is needed to manage current and future demand for healthcare. Without an increased and ongoing focus upon it, it's therefore likely that increases in activity will be short-term and services risk being unable to pivot or react to changes in demand into the future. Earlier this year, I produced a report on the delivery of the general practice contract in Scotland, which is clearly a critical component of how we deliver a preventative, local, community-based health service. The Scottish Government has committed to prioritising primary care, but direct spending on general practice has started to decrease in real terms between 2022 and 2024. It fell by 6%. Further to this, investment in general practice in Scotland only represents 6.5% of the total spend on health and social care services. In recent months, however, we've seen some important developments in prevention ambitions in Scotland. The Scottish Government and COSLA published their Population Health Framework together with their colleagues from Public Health Scotland, which begins to set out really vitally at a national and local level how the different spheres of government intend to work with their public service partners, community organisations and business to focus upon increasing primary preventative measures such as improving the conditions upon which people work, live and grow. You would expect me, I've been trained in this in my working life, to be sceptical and follow the evidence. That evidence of how cross-government, cross-sector collaboration, how all that comes together will be a key determinant of its success. Public leaders, quite rightly, recognise that delivering effective change cannot be done with one organisation alone. But perhaps we too readily talk about collaborative leadership without moving beyond what does that mean and when. The specifics of an action plan will be fundamental to the success that we are called upon to deliver to address the challenges currently facing us. We need, the Scottish Government, its public bodies, need to focus more on longer-term reform, inevitably making difficult decisions, difficult prioritisation about what the NHS should potentially stop doing. This is a really emotive area for service delivery, but it's not one that's new to any of us. The NHS, health and social care, and really all parts of public service prioritise day in, day out. Clinical strategies refer to the need to prioritise and stop delivering some aspects of service. Taking that further into a broader conversation could well be one of the next steps about what Scotland needs to do to deliver its public service. And again, this isn't new. There have been hugely innovative approaches within Scotland already, the drive for realistic medicine being one of those key elements. And those difficult choices will need to be made about what level and types of service can be provided in the future, including how and where those services will be offered to patients. And change almost feels inevitable about what the overall size and shape of health and social care services will look like into the future. And it goes without saying that those changes will affect not just today, but the future generations of Scots too. The temptation can be that us as leaders, the elected officials amongst you, are best placed to know and make those difficult decisions. The success will only be guaranteed, however, if that's done in a fulsome, collaborative way with patients, communities and their families, Scotland's third sector and businesses too. Post-pandemic, within that context of financial challenges, a growing backlog of care, there needs to be a range of plans and policies in place for the future delivery of healthcare. The shift away from recovery to reform requires the Scottish Government to lead and develop a clear national strategy for health and social care. Chris was telling me that he's joining you later today, but in June of last year, Mr Gray, the Cabinet Secretary, described this overarching vision being a Scotland where people live longer, healthy and fulfilling lives. And it's supported by 4 pillars. improving population health, a focus on prevention and early intervention, providing quality services and maximising access, with all of them underpinned by putting people at the heart of those services. And also, at the time, the Cabinet Secretary was very clear that a strategy to deliver this vision wasn't necessary because the Scottish Government existing plans and strategies already covered it. Our view at the time, and we set this out in many of our annual reports on the NHS, was that this restatement of the 2020 vision, and a pre-pandemic vision at that, was reliant on many of the extant delivery plans. And without setting a clear delivery plan, it was unclear to us where the national priorities and plans for reform were, how these would be delivered, how progress in achieving them would be measured and monitored. We were delighted, or welcomed. The Scottish Government then put plans in place to support reform also earlier this year on delivery of its stated vision. The Operational Improvement Plan, the Service Renewal Framework, alongside the Population Health Framework, are intended to provide that framework for reform for the next 12 months, the next 5 years, out to a 10-year framework. At the heart of both the Operational Improvement Plan and the Service Renewal Framework is an ambition to shift the balance of care into the community. I think I would say again, though, colleagues, the difficulties of delivering upon that ambition can't be understated. I'll say more about this as a short teaser about our annual report on the NHS in Scotland, which we'll be producing over the next 4 or 5 weeks. But it's clear that the challenge and the ambition is not new. Campbell-Christie's Christie Commission report set out much of this in 2012. The Public Bodies Joint Working Scotland Act in 2014 also set out a shared intention to ensure that health and social care was well integrated in Scotland, that people receive the care they need at the right time and in the right setting, with a focus on community-based preventative care. For all of you who work in the sector, the patients and families who receive services, the reports from Audit Scotland and many other organisations, though, confirm that we haven't yet delivered upon that ambition to shift the balance of care away from large public acute hospitals into a community setting closer to home or at home. And I don't wish to be a sceptic, because given the financial and demand pressures facing Scotland's health and social care services, this ambition has to be delivered. We have to make this change. I reported on the limited progress about making that shift from reactive into a preventative space. One of the challenges of making the shift towards prevention is that it takes time. It takes time for leaders, clinicians, and it takes time for our elected officials. When finances and public services are under pressure, there is a natural temptation, a seductive one, to prioritise the short-term pressures at the expense of the medium and long-term investment and change that we need to make. In Scotland, we continue to measure the success of public services in a largely short-term, service-specific set of indicators. NHS waiting times, A&E waiting times, they matter. They sure matter if you're sitting at one of Scotland's A&E departments waiting for treatment. They don't necessarily tell us about the health of the nation, though. And on that, I think it's an important step that the Scottish Government is currently taking stock of what it calls the national outcomes. The National Performance Framework is an ambitious, a broad suite of indicators to set out how and where Scotland is performing. But it hasn't been working as intended. Perhaps too many indicators, not enough good quality data to support examples of whether public spending is working and delivering the outcomes as intended. We know that that's under review, and perhaps a timely review, given some of the challenges that the health service and public spending, public service more widely, are currently facing. And that effective collaborative leadership that I referred to, it matters. Successfully implementing those long-term reforms will require strong political, executive, clinical leadership to address the current operational and financial challenges to deliver those redesigns that we need. And as I've outlined, the NHS in Scotland is experiencing immediate financial challenges, rising demand, operational pressures. There needs therefore to be a sustained increased focus on improving the health of Scotland's people to reduce the pressure upon NHS and social care. Difficult decisions are unavoidable. And yet I know none of this will be easy. We will always be in an electoral cycle. And some of those challenges, though, will get harder if we continue to make those short-term decisions and don't capitalise upon the strategies that have been set out over the course of the past few months. In closing, Audit Scotland's audit work regularly reports on implementation gaps between policy ambition and delivery upon the ground. There is an immense opportunity from the strategies, the collective will to deliver change and improvement to the people of Scotland, the experience that they get and the health of the nation. To embolden our leaders to make that change across Scotland, working with our health and social care providers and partners is an imperative that we grasp the opportunity that reform of services can bring today and the months and years to come. Thank you.
Well, thank you very much, Stephen, for a bracing and frank talk there. Not a surprise to those who've been reading your reports and growing increasingly alarmed as time has passed. You mentioned that 40% of public spending currently goes on the NHS, and the Scottish Fiscal Commission has suggested that could rise to 55% by 2075. So budgets are increasing, but performance isn't improving. Waiting times and lists remain too long. Hospital productivity is down. It does feel like we can continue to funnel money at healthcare, and it barely touches the sides and certainly isn't leading to an improvement in performance. It's a basic statement, but money is not enough, is it? That we're not talking, money is important, investment's important, but on its own, that's not going to solve the problems that we face.
Yeah, I think that's a fair assessment, actually, that, as I mentioned, every year we will have record investment, and yet the factors that produce the benefits of record investment aren't always there, especially looking at the capital changes, the constraint of the budget, the ability to invest in new services, new technologies. People are arriving in a different state into hospital than they once were. All of the evidence analysis will suggest that we need to do something different, a transformational approach, rather than continuing to invest directly in health and social care. And I don't think it's terribly controversial to say that the determinants of good health and life aren't solely within the hands of the NHS. I'll certainly not name him, but I'm now since retired senior exec, would say, well, actually, the NHS could be renamed the National Ill Health Service if we don't sufficiently recognise the impact that education, training, economic opportunities, housing, welfare can have upon it, Chris. So we could continue to throw more money at it, but I don't see that as the answer to the collective benefit of Scotland's people.
So the Audit Scotland and the Scottish Fiscal Commission, which are my two sort of heroes of the Quango system, because they speak truth to power pretty fearlessly. You've both produced a series of reports which have challenged government and decision makers, policy makers. As you keep saying, we're going to have to be radical and we're going to have to get on with it. We don't really have an option. Now, what's your sense of the response from the centre of government to this? Because we accept it's hard to do this stuff. We know there's a political cycle. We know that politicians don't like being unpopular, and a lot of the things we're talking about would not necessarily make them super popular with the electorate, or maybe people in this room as well. What's your sense of, do they get it?
I think they do. I think everybody gets it, but making the change and moving money from one part of the system to another is hard. And we make recommendations. I think that's right with my organisation. We are not, unlike some audit organisations in other parts of the world, we have no powers of intervention. I think that's absolutely right. It's not my role. I'm not an elected official. Politicians have quite rightly secured the mandate to deliver change. My role is to make recommendations about how well public money is being spent and to offer assurance to people, the Parliament, about 50, 60 billion pounds of annual public spending. So I think there's a shared recognition of how money is being spent. And go back to your earlier point, I don't see a sense that we could continue to throw money in a sustainable way at it, because there's a limited amount of resources available. So unless there's a radical redesign of tax and spending in Scotland, this will largely be the resource that we have to deliver public service. And if that's not keeping pace with the experience, the health of the nation, then I think it makes a strong case for why change is required.
And just before I come to Sarah, you mentioned the Christie Commission, and the word prevention is very much a buzzword when we're talking about health reform at the moment. So we've been talking about this for well over a decade, and yet we probably still incentivise short-term view of healthcare, dealing with short-term pressures over the long-term view. Why has there been so little progress on prevention, despite the fact it seems to be something that's debated every week in the media and in politics?
I think it's about choices, actually. It's about choice and pressure and demand for how we allocate resource. And it's really difficult. And I would never want to be flippant to say, just reform this system. It's so, in many ways, it's so successful as a system about how it is created, its structures. People know their place in it. People have spent their working lives acquiring expertise to deliver the service. And we might have to move into a place where we will deprioritise certain ways of spending and what that means for people's careers and interests. And that's why I think some of the plans that have been set out over the course of the summer will have to start to get into that territory in terms of to take it forward. That we can all subscribe to a narrative of, and evidence will tell us, that prevention leads to better, longer-term outcomes than an intervention. And yet, we've not been able to do that. We've not been able to change where we're spending money, whether we need to change structures to do so. But I think we should guard against throwing all our eggs into we'll all be collaborative. And collaborative leadership will be the sole way in which we will deliver outcomes. Because inevitably, some of that might have to be an element of sacrifice and change. And I think these are the decisions that we'll be facing executives and leaders in the months and years ahead.
And just quickly on the deprioritising, as you said in your speech, the NHS is going to have to stop doing some things if we're going to be able to afford. Is there any detail on where you think that might be looked at as that policy matter for politicians?
So I think it is a policy matter, but I mean, this is a current strategy. This is a current reference in one of the Scottish Government's clinical strategies, that we will have to stop doing some things as a country. And I think it's true. We do prioritise currently. So there are some services you just can't get on the NHS, whether you would like them or not. And it will come down to affordability. But these will be the important clinical leadership decisions that will have to be made about where we spend resources, whether we invest differently in primary care services, whether we need to have the hospital model in Scotland, the structures that we have in Scotland, I think are all the decisions that we'll rightly want to consider really fully in the years to come.
Okay. Sarah, you worked at the most senior levels of government as a senior civil servant for many years, and obviously you have therefore had a sort of very close-up view of attempts to reform any number of public services such as there has been. What did you take from that in terms of the difficulties, the barriers to reforming those services, and why it seems so hard for Scotland's politicians especially to make change?
So thank you, and thanks for inviting me to be part of this conversation today. As I guess as Stephen has already pointed to, I think it's important to recognise that there are not easy answers to that question, and this room is replete with people for whom I have immense respect, who have been trying to answer that question for a long time, and I think that's why we're here today, because we want to start teasing it out and build a sense of shared responsibility for what happens next. I think it's really important, and Stephen's been kind of pointing at this, that you need to focus on the purpose of reform and the desired outcomes, and I wonder if that's not always been as central in the past. And reform needs to pay as much attention to culture and behaviours in the existing system and the motivations and what is it that leads people to behave in the way they do as it does to the technical things that you might do. And again, I think Stephen's been very much pointing at that when he's been talking about the barriers to reform. And I recognise that not just in relation to health reform, but in relation to reform more generally. And I think that's often underplayed when talking about reform. The human factors, the kind of understanding why is it that everybody in the system gets up in the morning and does what they do. And the vast majority of people, of course, are all trying to do a good job, but the definition of what is a good job and what is the thing you're trying to achieve is made by a whole set of motivations, incentives, worldviews, which at the moment are leading to the outcome that Stephen has been describing and not to the degree of reform that we need. So to use the language that we use around change, it's as much an adaptive problem as it is a technical problem. And simply focusing on the technical without focusing on the adaptive challenge, I think is difficult. And it's not that that hasn't been tried in the past. And particularly in the post-Christie era, there was quite a lot of careful thought given to what does it take to work collaboratively. It doesn't just happen by asking people to do it. It requires people to make sacrifices, to think differently. But I think what I observed over time was that that type of thinking got a bit pushed to the margins, and the more kind of heroic, let's just set a plan and try and go for it, leadership became more prioritised, particularly in the NHS. And I think, going back to what I was saying about the purpose of reform and the desired outcomes, both the plan that the Health Secretary published in the summer and also the Scottish PSR strategy, the Public Service Reform Strategy, which covers a wider series of public services in Scotland, is saying that its aim is for services to be more preventative, for them to be better joined up, to deliver better outcomes for people. And if that's the aim, then we have to start with that question of, so what's getting in the way of that at the moment?
And therefore, what does it take to drive through successful reform? I mean, are there any examples you could use from your experiences in the past of how reform has been successfully navigated? It doesn't feel that we've been very good at reform during the Holyrood era.
So I think it does take that collective shared ambition and being clear that, as Stephen was saying, collaboration doesn't necessarily mean that everyone brings what they want and gets what they want out of it, that it requires confidence to have a very clear vision of where you want to go, but to recognise, particularly from central government, that the getting there is not something that central government can own itself, and that the path has to be walked with others, and that the individual how of reform will not necessarily be dictated from the centre. And again, I think Stephen was alluding very helpfully to all the different players that have a part in bringing about different outcomes. And the role of government is to recognise those different players, but not to stipulate what every person has to do or every player has to do, and how and when. And I think some of the, and again, some of my knowledge of things is a bit out of date, so I'm not going to kind of pull for individual examples that I'm probably not as much on top of as I should be. But where I saw in government, things started to open up in my time and change to happen, it was where people were prepared to come together, to take off, at least for a period of time, the hat that they wore in the kind of formal external role that they played, and to talk about some of the difficulties that they were facing trying to share services. And I remember particularly in that immediate post-Christie time, when possibly the attempts to have a more genuinely effective partnership between central government and local government, particularly maybe in the kind of 2007 to 2011 period of time, was one when people were prepared to name some of the difficulties in trying to work towards better solutions.
As you say, the how of reform is not something for Bute House to decide. You need the expertise of the people that are involved in delivering services, but it can't happen without an energy and direction from the centre, whether that is a minister with real passion. I might say Michael Gove at Education, whether you agree with them or not, he went in there with real passion. You can see West Streeting is trying to do things in the English NHS. How important is it that a figurehead individual puts their weight and, I guess, their democratic mandate behind delivering this stuff?
Yeah. So it's a really interesting question, I suppose, particularly as we sit here in the run-up to an election. And it's a bit of a double-edged sword in this context as well. So on the one hand, I think it's very difficult to, in our system, to drive a programme of reform without enthusiasm, to use your word, without the ability to describe and hold a vision which other people feel that they want to come together around. So, if you think of the counterfactual, is a lack of enthusiasm, is a lack of ownership, is a lack of drive going to get this? No, it's not. On the other hand, I think we've also seen, and again, Stephen, I think partly alluded to it, that there is a risk, of course, that can tip into something which is so party politically owned that it gets in the way of everyone coming together around the shared vision. And given the long-term nature of this, thinking of the Fiscal Commission projections and even Audit Scotland's horizon, if we are not capable of thinking beyond political terms in relation to the health service, then we're not going to address these issues. So political leadership can play both ways, and I think that's one of the really big challenges, and hopefully discussions like this can start to address some of that.
Well, one of the challenges we face, I'm sure everyone in the room agrees roughly with what's been said, but we do have an election next May, and at the moment the politicians are running around with their cudgels taking swipes at each other, and we're obviously asking them to come together and think about the longer term outside of the democratic cycle. And then we'll have a Holyrood election, and according to the polls we're going to have a parliament of minorities, even more so than we've grown used to. It looks like Reform are going to win a bunch of seats. It's not clear that we'll be able to get a coalition government of one stripe or another. And so asking politicians at this stage to step outside of the politics when you have, they're fighting for their seats, they're trying to win power, and then after that they're going to try to be balanced. It's all about the numbers. They'll be trying to balance the number of seats they have, the number of seats the opposition parties have. And when Holyrood was set up, I remember I was there as a young journalist, and the whole idea was that it would be more collaborative. It wasn't two swords lengths. The shape of the debating chamber was designed differently for that very reason. The voting system is different for that very reason. But it's every bit as combative as Westminster, perhaps because the Constitution has dominated so much, so there's been a lot to go at. So, I mean, Stephen, is it possible in the current climate, and the way our politics is at the moment, there's arguments over identity, it's quite a brutal environment. How do you get people to step outside of the tribal politics?
That's a tricky one for me. I think the answer is, what is the evidence telling us that can be achieved in a 12-month, 3-year, 5-year electoral cycle? I agree with Sarah. I think the problems, the challenges facing us will span certainly more than one electoral cycle. But tapping into the motivations of elected officials to play their part collegiately on that will be a key challenge, and maybe the electoral projections will help, maybe they'll hinder. But there are really good examples within the Parliament of where political allegiances can be set aside for good effect. As you know, Chris, the main recipient of my work is the Public Audit Committee in the Parliament that is, of course, has elected MSPs of different parties, but they will discharge scrutiny in a non-partisan way. And I wonder if, I wouldn't necessarily advocate that solely as the model, but finding a way that we can bring the brightest and the best to address the challenges of the future. Not just politicians, but executives and leaders from across public life will be the key to addressing the challenges that are laid bare.
Sarah, same point to you.
Yes, I agree. I think none of us here, I imagine, is politically naive, and instinctively the period immediately after an election is probably a better time to be opening some of these topics up than the period immediately, or not opening them up but taking action on them rather than the period immediately before. But picking up on Stephen's point about evidence, there's an interesting report out by the Nuffield Trust this September, which it was looking at lessons for England and their 10-year ambitions for the health and care sector that can be drawn from reform in Denmark and Ireland. And one of the key findings that they found was that cross-party political consensus and commitment were a fundamental factor in shifting the balance of care from acute to community settings, and that these reforms were developed by independent committees and adhered to across political divides. And I know we're going to be hearing later from a colleague from Wales, and I know that similarly in Wales, their long-term NHS plan and health plan is one which has cross-party support. So I think, as Stephen says, if we're going to follow the evidence of what might lead to change, then that's a valuable lesson to listen to. And of course, there's a kind of form follows function point here as well, which is that, yes, we do work within a very combative political setting, media context and so on, but there are choices for all the parties, both in government and in opposition, about how you engage in these issues and whether you primarily see them as something you want to think of through a combative lens, or whether you want to think of them through a collaborative long-term lens. And I think there's a really interesting challenge there for all the parties in Scotland, but it's probably a post-election challenge rather than a pre-election one.
Is the civil service a problem or a solution when it comes to delivering reform?
Well, it has to be a solution,
But
clearly.
is it?
So in my view, that is what it is set up to do, and I don't see any evidence that it's an impediment to it. But I think it's really important, and a pre-election time is exactly the right time to be remembering that the role of the civil service is, above all, to provide frank, full, fair and impartial advice on the evidence about what supports reform and what will make that happen. And I think the publications that Stephen talks about and that I've alluded to as well, all of those, although written in the name of the Minister, will be developed on the basis of advice from officials. But again, maybe things like dialogues like this can do and events like this can do is to create spaces where officials can get access to good practice elsewhere and reflect and recognise that there is support for having those conversations with politicians. And they will be, I'm absolutely certain that the civil service in Scotland, as it always does, will be spending the period between now and May thinking very carefully about the advice that they offer to an incoming administration of whatever political colour. Mm-hmm.
Is there a sense in Scottish politics and Scottish government, not referring to any one party here, that there has been a sort of fear of failure, a sort of lack of willingness to innovate because there is just a concern that if it goes wrong, they're going to get in trouble? It's surely better at least to try and fail rather than just to continue with the status quo, because we will fail. We will try things, some of them will work, some of them won't. But it feels like in the Holyrood era that we've been less willing to experiment. There have been a few things, but not as much as there should have been. That we're willing to experiment with innovative policies, to rip things up by the roots, to stop doing things, to lead from the front, to take the voters with you rather than to follow them. Is there a sense that we're not really adventurous enough in our policy approach?
So I think there's some examples of that. And my role, my organisation, I would recognise can be a contributor to that. We often hear from public body leaders that we don't want to do that for fear of falling foul of what the auditors
or the media
or public audit committee or wherever else. And there's some high-profile examples of where we haven't got things right as a country, as whether it's perhaps regrettably ferries is the most recent issue about not delivering public policy successfully. I guess there's two other factors. One is that a great many things are done really well and as intended. As a point I stress regularly to MSPs that the vast majority of public bodies deliver what they're asked to do. They spend the money they're allocated properly and they deliver the outcomes that they wanted to. But at the margins, it's going to become harder. Talk about the trajectory of health spending as being one of the catalysts as to why we need to change. And we have to change. So for all of us, we need to get more comfortable with failure, that some of the investments that we will make won't succeed. We have to embrace technology in the way that business is. And we have to be really careful about recognising that, as I say, Chris, some of that is going to go badly. So there will be another IT failure in the Scottish public sector. I have no doubt about that. I don't know where it is, but I know it's coming. But actually, that body, instead of being castigated, actually think, at least you tried. The bigger failure at the moment is not taking some of the innovative steps and remaining within the status quo because the world is changing. The demand of public service users, patients in this context, is changing, and it's for public bodies and public leaders to respond and perhaps, with your question, become less risk averse, but do so in a controlled way that's got the project plan, the governance, all of the infrastructure that gives the best chance of success, but recognising there are no guarantees.
So there are a couple of imperatives, really, I suppose. One is that we can see across the West, but Scotland's not immune from it, that a chunk of voters are starting to move away from the mainstream towards less traditional parties. And the answer to that, I would guess, is for the mainstream, the middle, whatever you want to call it, to show that it can get stuff done. Because the reason people are moving is they feel that it doesn't really matter who's in government. Nothing gets better. The schools are rubbish. The NHS is on its knees. Cost of living crisis is a disaster. I'm exaggerating, but that's what you'd hear from voters. So there is a kind of imperative for those parties that are likely to be in power to find ways to come together and to actually show that traditional form of politics, that democracy can deliver the things that people want it to.
Yes, and I think there's two aspects to that as well. There's some really interesting work done by the OECD in trust in institutions and what drives trust in institutions. And as you say, I think a lot of the movement of people to the fringes of politics at the moment can reasonably be interpreted as a loss of trust in institutions. And one of the elements that can help to restore that is seeing things working and seeing politicians working together to do that. But another is in the nature of the dialogue with the public. And I think, and we'll probably come on to that a bit later this afternoon when we look at some of the polling data that I know you've commissioned an association with today. Because if politicians continue to either feel pressurised into or simply conform to a model which pretends that everything in the garden is wonderful and it will be wonderful and that just by saying that something will happen, it will happen, then it's hardly surprising if people are quite quickly disillusioned when the reality doesn't meet that picture. And nothing that Stephen has said this morning in his opening remarks is classified. All of that is publicly available analysis, which I think we ought to see as our collective commons. We own that. It's not owned by Parliament or the government or the NHS itself, indeed. That is where we are at the moment as a country. And of course, you have to find the right ways of talking about that and explaining it. But I do think that any type of cross-party collaboration around the future of the health of the population in this country and the role of the NHS in that has to find a way of sharing the current situation in a meaningful and realistic way and what it will take to address it and the nature of the types of changes and the choices that have to be made. Because all too easily one could see the choices and prioritisation that we were talking about earlier becoming manipulated into being more of a story of failure, when actually it's a story of decision-making and reform and leadership. So I think how the parties work together, but how we engage with the people of Scotland on that really matters.
Yeah, very good point. Okay, we've got 15 minutes for questions. If you'd like to ask, now we have microphones, I think, coming. You're going to be very fit by the end of the day, I think. So the gentleman in the centre there.
You can also come to these microphones and press the other one.
Oh, right, okay.
Always a mistake to be the first one. My name's John Smythe. I'm a professor of cancer medicine at the University of Edinburgh, and I've been an NHS doctor for 50 years. I came today determined to be positive, and I'm struggling, Stephen, but I wanted to thank you for being so honest about what everybody in this room knows is the fact that this is unsustainable. And one of the things nobody's mentioned yet is the consequence of medical research, which is going ahead in spectacular fashion, and Scotland's a very major part of that. That's only going to increase the demand, make people live longer, etc., etc., etc. My point is that I think it seems absurd that with all the data that you have to give people, the facts, that we rely on politicians to actually make the final decisions about where the money goes. Because these people, and I'm not wanting to be rude about anybody all day, but it's absurd that you have politicians who've only got a 3 to 4 year vision making the sort of decisions that are necessary now, even if we didn't have the catastrophe we're in. And, morale in the medical profession at the moment is an all-time low. And there's nothing that gets people more upset than a Minister of Health going on the television saying, I have decided that we're going to prioritise this, that, and the other. So surely we could find a way, and Scotland could lead the world in this, of actually getting away from the party political, and Sarah mentioned this, the party political decision-making, and actually have something like a commission on healthcare where the government in office give a budget, but then you have some 15 to 20 people, wise men from all sectors of the relevant society, actually making the decisions on a 5 to 10 year plan, not worrying about, and it's going to be absolutely catastrophic in the next few months because of the hogwash we'll hear from different people over something that is the reason everyone's in this room today. So an independent body of people making the decisions rather than the politicians.
Good morning. Actually, that's a very interesting perspective, and respect the insight from your professional background. In many ways, I'm not sure if I'm the person to answer your question, rather the politicians themselves, whether they would be willing, as you suggest, to step aside from their responsibilities. And I was at an event a few months ago, and forgive me, I'm not trying to align your question to what I was asked at that event, but somebody said to me, well, do politicians, are they capable of making these decisions? And my response then was, perhaps some of this, that they put themselves up for election in the system that we currently operate. And yet there has been many suggestions, discussions over the years, I think along the lines that you referred to, can we elevate some of the challenges that we're currently facing out of the political cycle? Whether it's, like you referred to earlier, Chris, when we were chatting of a Smith Commission or a national conversation, I think is the other topics. How do we engage the public, experts like yourselves in the audience today, to influence what I suspect will always be a political decision? Given that health and social care is a devolved matter to the Scottish Parliament, I struggle to see how that final accountability will rest other than with the elected officials that put themselves up for election. But I think there does need to be a step alongside the annual budget setting arrangements that we have that can allow the public to be engaged, informed by the experts, to make the kind of difficult decisions that I think are so necessary. And lastly, just to acknowledge the really vital point you make about the pace of change that is so relevant. The demands will increase. There barely seems to be a week goes by without some startling new invention to improve outcomes and life chances for people. The public want that. Of course they do. And yet I fear that rationing or prioritisation will make the debate even harder in the years to come without this level of national conversation, convention of some description. But I suspect, sir, that the politicians, in my view, probably rightly, will always be the ultimate owners of accountability for health and social care.
Sarah, a more technocratic, expert-led approach to not just advice or policy development, but decision-making, where would you stand on that?
I don't really think I've got anything to add to what Stephen has said. The reality is that we operate within a system of democratic accountability, but I think it's a really interesting challenge. And you could apply the same actually to some of the other big multi-term challenges, the environment, net zero and so on, where at the moment we do not have an effective mechanism of airing these in order to make decisions for future generations, to borrow the language of the Welsh Act that attempts to do that. And I suppose the other thing I would add was I would really strongly endorse what Stephen said earlier about the current review of the National Performance Framework. In some ways, in relation to that, what is of less significance is the particular long-term outcomes that you specify in that. What's really significant is how is it that we work together in order to identify what needs to be done and how to put our shoulders to that. And that cannot be simply one perspective in the system. It has to be broader than that.
Okay. Another question. Just checking round. Yes, the gentleman, it's an easy one for you, Morgan.
Hello, Lachlan from The Sun. I was a little bit intrigued and a bit terrified about what you said, Mr. Boyle, at the opening, that whole disciplines might have to be sacrificed for the greater good. There's been a lot of chat about top-down, about what the politicians can do, but if you start sacrificing whole disciplines, there's going to be pushback from the unions, from fraternal bodies like the Royal College here. So what would be your message to the unions to say, you're going to have to retrain or retire for the greater good?
Yeah, thank you for that question. I think the reference we make is to an existing Scottish Government strategy. So this was in our report, on the annual report on NHS 2024, that made reference to the clinical strategy, which set out that the NHS will need to stop doing some things. What our question really back to the strategy was, and what does that mean? So rather than for me to say it should be this or that, I think back to the earlier question, I don't think that's a decision that an auditor should make, but rather one for clinical leaders to give advice through civil servants to politicians about how all of this is captured in a wider programme of reform on the basis, I think, hopefully what I also set out is that the challenges we face today are clear, whether they are in terms of waiting lists or waiting times, constraints on investment. And if we keep doing the same things of investing in additional resource and more people, but we're not seeing the benefit of that. So addressing the productivity challenges need to be part of this collective stock-take of how health and social care will be delivered. But the very heart of your question, I think, is one for others rather than an auditor.
Okay. Yes, the gentleman.
Thank you. I'm Alan McNeill. I'm a urologist here in Edinburgh, trustee of Prostate Scotland and co-author of a paper we've put together trying to address some of the problems we're discussing today. And I think a few comments, if I may. I think understanding the history of why we are where we are might help us get better in the future, because this is about making things better, isn't it? We all want a healthcare system that works for the patient, irrespective of their ability to pay. That's what must be our ambition. And if you go back to 1983, the Griffiths report said there were too many vested interests getting in the way of delivering that. And it was interpreted by the Thatcher government that those vested interests were the consultants. So we then saw an age of professional politicians introducing what you might call a managerialist approach to delivering healthcare and a focus on groupthink, and we lost professionalism and proper clinical leadership. And that's why the UK, not just Scotland, is kind of in the mess it is compared to our European neighbours, where clinical leadership prevails. And in many situations in Europe, the governments have devolved or decentralised healthcare to let the system deliver it better. And they will regulate, but they won't seek to control. So one of the challenges, I think, is persuading our politicians that we do need some form of independent commission that oversees it, and they need to release the power. But then what do we elect them on? That's their problem, isn't it? And we've sought to write a paper to generate a discussion with the public to allow the politicians to move into that space. So it's not their idea that they're going to get kicked by their colleagues. And I think this group should be sort of amplifying that message to them. Let's have a proper discussion with the public about what this looks like, and forget the political arguments, because that will keep us, in the same mess we're in. So I would commend our short essay to people, and I commend you for hosting this. I think we do need a prescription for change, and I would agree with Professor Smythe that must be some relinquishing of power, if you like, by the politicians with a spirit of maintaining a health service. But how do we persuade them? That would be the question to the panel.
I do think when we're asking politicians to do hard things, and it's something we try to do as a think tank, which is to provide evidence and ideas and give them some sort of covering fire so that they can run towards the problems a bit, because there is inevitably a lack of confidence to do that if you've got to get re-elected in a couple of years or whatever. You've got to be very careful. And so I think, the people in this room, the organisations that you belong to, the expertise that's out there, if that demand and desire for radical reform, for change, is clearly out there. And I think the public are ahead of the politicians on a lot of this. I think they understand that things can't stay as they are. But I think it's very important that you write papers and you speak out and you engage with the public and you engage with the media and you engage with the politicians and the policy makers to say, we support change. We will have your back if you do this, and we will come out positively if you make some of these efforts, and don't be afraid to fail, because that's one of the big things that holds them back. But anyway, would either of you like to?
I suppose the only point I wanted to pick up on was that final one that you made, and you just amplified there, Chris, I think. And again, people have heard in this room have probably heard me say this a lot of times, that whenever we identify a decision or an approach as being a really difficult one for politicians, one of the things that we can collectively do is to de-risk it by saying very clearly what we think the problem is and what we think some of the routes to change might be, and being prepared to acknowledge when politicians do things that are difficult, even if they're not the whole way, even if they're not perfect, because actually that broad-based coalition of support matters more for change than I think we often recognise.
Yeah. Okay. Time for one last question. Yes, there's a lady at the back there. We could you both, actually, if you're... Okay.
Hi everyone, my name's Rajti and I'm one of the elected members of the Scottish Youth Parliament for Glasgow Pollock. I've got a quick question for Stephen. So you mentioned that money isn't the sustainable fix for inequality in healthcare, which I completely agree with. But what about specific conditions like, the experts in the room will know this better than me, like PCOS, endometriosis, adenomyosis, which are significantly underfunded? There isn't much collective action and effort that will fix that except research money. So what's your opinion outside of tokenistic policies? What do you feel would address these inequalities?
Good morning. Thank you so much for your question. So perhaps much like my earlier answer is that there will always be more demand, more call on public spending than the resources that is available. In many ways, the system that we have of spending has been an incremental one. And so I don't really use very often the language of interests or vested interests. Tend to stray away from that. But what I would understand is that the system has grown incrementally over the years, really back to the experts in the room with the history. It should challenge itself, therefore. Can it adapt to the changing nature of medical conditions? Is public spending moving in an agile way quickly enough? And Sarah mentioned accountabilities earlier, and I think that's a key part of it, that how we measure success in Scotland is really quite narrow. What are the factors that will be judged for the different executives, whether, and even for political leaders, that they are successful in their jobs? And, in my organisation is a part in this too. So, you'll break even. So I might mention in my speech that health boards, one of the success factors, they'll say, well, we need to break even each year. And if we don't, we're in bother. You'll then be brought into an escalation route from the Scottish Government or ultimately up to special measures. But is that system allowing for changing conditions, demands, inequalities? We absolutely need to challenge ourselves. And that is all of the various factors that will lead to supporting Mr. Gray in delivering his vision. Is it agile enough to deliver the success factors? So I do have some cause for optimism. I think the developments over the course of the summer feel really significant. Those publications set out a new ambition and approach. What comes next, though, as well as the national conversation, is really some of that quite grounded approach. What steps are we going to take? The key actions, who's going to do them, how we're going to measure it, that we've got the right data. I think quite reasonably, because I've not spoken a great deal about that, but in spite of all of the vast swathes of data that we have, it's not good enough. There's real gaps in data in some of our parts of our health system that can allow decision makers, can allow experts to say how we are spending, how we can move from some of the challenges of today, addressing all the conditions and ambitions of Scotland's people for the years ahead. So I'm trying to sound a bit more positive than I maybe have in other parts of the discussion this morning, but thank you for your question.
All right, well, we're pretty much out of time. I'm going to finish with one question which requires a very short answer for both of you. So out of 10, how confident are you that the politicians of Scotland have what it takes to deliver the things that we're talking about today? 1, 2? Put you on the spot, sorry.
Yeah, I don't really have an
Oh, come on.
score out of 10. I'm going to get splinters. I'm going to sit on the fence for it. I think it's a hard job being a politician. I don't doubt that for a second. And it'll make their job easier, though, to listen to the experts and what the public wants. So maybe today is about really making the case for change. That if people in the room believe that there's a need for reform and sustainability, is taking that message out and persuading the public that some of the challenges that can be overcome absolutely involve them, and making the politician's job more straightforward. I've got huge respect for all politicians. They put themselves up for it. Democracy is at the heart of it, and we'll be going through that electoral cycle. I'm tempted, but I'll probably resist the idea to give you a direct answer. So you asked for a one word, I think.
With all those splinters, you've got a room of medics that can help you out with that later. Sarah, you're freer to say exactly what you think, but I wonder if your civil service background will prevent you.
Well, it's not so much that. I'm just not entirely sure it's helpful, but I actually thought you were going to ask a different question. I thought you were going to ask out of 10, how optimistic are we about the potential for change? So I'm going to answer that question
kind of what I
instead.
was asking. It's the same thing.
So I am a natural optimist, and I know that that means that I see things through a particular lens, but I actually think that the growing sense of recognising and articulating the nature of the problem, including by government, and the increasingly broad-based coalition of people wanting to find a solution, feels like it's reaching something of a tipping point. And I think, as we alluded to earlier, the electoral politics post-election potentially open up an opportunity. So I think I am more edging towards a 7 and 8 in optimism than I might have been some time ago. So
we have a number, ladies and
instead.
gentlemen. We have a number. Well, listen, if I could just ask you to thank Stephen and Sarah for their brilliant contributions.